So, thanks for the invitation. I'd like to present the results of 100 cases of central serous chorioretinopathy, which were treated by the microsecond posing mode with the Navilas laser. First, just to remember some facts of central serous chorioretinopathy. The incidence is 1 to 10,000. Majority are men, middle-aged, so onset is in their best years. You can divide the CSC into acute and chronic. Cutoff is between 3 and 6 months. There are different definitions. Risk factors include stress, steroids, and many other illnesses seem to be associated to this disease. Symptoms include a reduced best-corrected visual acuity, contrast impairment, metamorphopsia, micropsia, and central scotoma. So, at first presentation, first-line treatment consists of closed follow-up visits and waiting, or taking of aldosterone receptor antagonists, as the subretinal fluid often resolves spontaneously. At the latest of 3 months, without improvement, a fluorescence angiography is indicated. Because we know as the fluid persists, the photoreceptors begin to die after 3 or 4 months. In cases with a hotspot and diffuse leakage, we first treat our patients with a navigated microsecond posing laser, and just after 3 or 2 laser sessions without improvement, we indicate the photodynamic therapy, as we know there's a consecutive retinal atrophy after years. When there's a secondary choroidal neovascularization, the intravitreal injections of anti-vasoendothelial growth factors are indicated. Now, I'd like to talk about the microsecond posing laser of our trial. We guess that the microsecond posing laser causes a sublethal temperature on the retinal pigment epithelium, and therefore it is a selective non-visible treatment of the retinal pigment epithelium. And this hyperthemia is thought to cause some change of the function of the RPE, and this leads to a proliferation of the RPE cells. So this closes the microtear, which we think of as a pathologic cause of the CSC, and this improves the pump mechanism of the RPE to keep the fluid below. So why do we use this laser in CSC? Because with the eye tracking function and the navigated microsecond posing mode, we can plan exactly where to treat, and so we have the possibility to treat foveolar hotspots, as you can see in this picture. So why did we do our retrospective analysis? Because there are already small prospective and retrospective trials which have shown a positive effect on the resolution of the subretinal fluid. So we had the question, how the effect of the laser on morphology, function, and whether there's any damage caused by the laser. These are our 5 sites from different countries and different continents which took place in our study. Everyone used the Navilas laser, which is a yellow laser with 577 nanometers. We have a continuous wave laser, which is cut into several hundred microsecond pulses without reaching the coagulation level. So you can imagine better how to treat with this laser. Here you can see our parameters with duty cycle, pulse duration, spot size, mean power, and number of spots. And there are different methods and opinion also about the titration which was used. So this is the big question which still remains unclear, which are the best parameters to treat. We observed 102 eyes, all suffered from CSC at least 3 months. Median age was 50, median follow-up time were 10 months, majority were men, and 26% took Inspra before the laser treatment. Most of them, with 50%, were defined as a chronic CSC, more than 4 months of onset of the first symptoms, 30% persistent, and best-corrected visual acuity in log-MAR at initial presentation was 0.34 and central macular thickness 325 micrometers. We had almost 40% with a hotspot and 60% with a diffuse leakage. Here you can see the results of our analysis, and there you can see that we had a significant reduction of the central macular thickness caused by the Navilas laser with a microsecond posing mode. At baseline presentation, the median central macular thickness was 325 micrometers, and at last follow-up 256. So we had a reduction of 63 micrometers. Here you can see the resolution of the subretinal fluid, and as you can see, half of all cases had a complete resolution of the subretinal fluid, 12% partial resolution, 30% persistent. And here you can see of our 102 eyes, in 65%, just 1 microsecond pulsing laser was sufficient to treat the CSC. 23% received 2 laser treatments and 4% 3. In 10% of the patients, they got another therapy as intravitreal injections or epineuron. Here you can see the best corrected visual acuity shown in logMAR, and we had a small significant improvement. 53% had a stable best corrected visual acuity, 33% a gain, and 14% a loss of more than 5 letters. To summarize, we saw a reduction of the macular thickness. We saw an improvement of the best corrected visual acuity. We didn't detect any side effects or scars, and so we have a safe navigated laser treatment which is stress-free and without pain. Also because we don't have to use a contact glass. There are some questions which still remain unclear. We didn't detect the spontaneous improvement as we didn't have a control group. And the big question, what I already talked about, which still remains unclear, is which are the best parameters to treat, which is the best dosimetry. This is how it's looking like when we try to get the busy, stressed CSC patients in front of the Navilas laser in our university in Göttingen. Thanks for listening. Enjoy the retina in Paris.